All right, thank you so much for having me. It's a great pleasure and a great honor. I was trained at MGH in McLean Hospital, so it's a little bit like coming back home. So the title of my presentation is Photobiomodulation for Alzheimer's Disease, Improving Brain Blood Flow. So this is a picture of our team at a not so recent Alzheimer's walk. And I'll just say right now, photobiomodulation means neuromodulating, so modulating brain function with light. Disclosures, as you mentioned, I'm co-founder of a company in the light space. However, no information related to the product of this company or to the studies of those products is part of my presentation. So first, I want to start with my why. So why me in general? What's my interest here? And I want to bring you back in a little journey here and talk a little about this scientist, Giovanni Pellizzi, who lived in the 1800s and 1900s in Italy, who incidentally studied a syndrome of the epiphysis, a gland that is particularly sensitive to the light. The reason I'm talking about this scientist is related to the fact that he also suffered from Alzheimer's disease. This is a picture of his summer house before World War II. And this was a family picture where he was with his spouse and his grandchildren. Now, to note in this picture is that this little boy actually is my father. So, so Giovanni Pellizzi was my great-grandfather. So now the house was bombed over the war. This was the house after being reconstructed. This is the next generation in the 80s. What you see here, it's the same type of picture, grandparents and grandchildren. I'm here, and this is my grandmother, Maria Paola, who was the daughter of Giovanni and Giovanni Pellizzi. And unfortunately, she also contracted Alzheimer's disease. And this is my father, who is now retired, but has been a neuroscientist, neuropsychopharmacologist at the University of Pisa. And he's also presenting cognitive decline. So you can imagine, you know, my scientific and personal interest in the topic. Now, the question is why brain blood flow, and why does it matter in Alzheimer's disease? So inflammatory changes have been well documented in the etiopathogenesis of Alzheimer's disease. We know that amyloid beta it links to microglia and eventually leads to acute activation of the microglia, which leads to phagocytosis of amyloid beta, which is a physiological clearance. However, when that becomes too much and when there are contributing factors such as systemic inflammation or obesity, lack of physical activity, or even local like brain trauma, that activation of microglia being sustained leads to much damage and neurodegeneration. What this picture doesn't show is that this becomes a factor that leads to greater deposition of amyloid beta and eventually overwhelms the system of the microglia and leads to even greater sustained activation and pro-inflammatory changes. So that's a well understood etiopathogenesis for Alzheimer's disease. And yet there's much to be said about vascular changes as well. In fact, the same contributing factor that you see here, whether it's poor diet, lack of exercise, pollution, toxins, genetic predisposition, systemic conditions like hypertension or diabetes also directly affect the vasculature. And that's a mechanism that is not beta amyloid mediated. So what happens is that the small arteries and the arterioles basically lose their normal adaptation with kind of response to, in terms of vasodilation, to different stressors or different needs. And that leads to relative ischemia, so lack of perfusion. In conjunction to also alteration of the blood-brain barrier, we call it like breakdown, which leads to greater exposure to toxins. Altogether, this ischemia and greater exposure to toxin then leads to damage. And that damage leads to now greater amyloid beta production. And then amyloid beta production that leads, as I already shown you, to several effects on tissue, also leads to a second hit on the vasculature. Now, what we are hoping for is that we can use the light to directly affect the vasculature and therefore prevent some of this etiopathogenetic mechanisms that leads to neurodegeneration and Alzheimer. Now, what we see more broadly at a clinical level is that there is a correlation in between being kind of cognitive function and the different stages of the clinical disease and decline in cerebral blood flow. These different colors are signaling different brain areas. Now, here you see the cognitive normal that has a relatively preserved cerebral blood flow. As you move to mild cognitive impairment, the decline is more pronounced, and even more so when you move to dementia. So definitely an important correlation. Other studies have also looked at this correlation. And this is a naturalistic study, population-based study that looked at the predictive value of lower brain blood flow in terms of risk for dementia, and look here at different cognitive dimensions. And what they saw in patients or subjects who had more than 55 years old at baseline is that their blood flow, or the lower blood flow, predicted significantly poorer global cognition and poor memory over time. This was also done and replicated by other studies that look at specific brain areas, such as hippocampus, where you see here as blood flow increases, the reaction times for retrieval of a spatial memory decrease. That means that patients are faster, or people are faster to recall about spatial memory. So again, a favorable correlation based on cerebral blood flow. This also has been shown in treatment studies. So when people, or patients, I should say, were treated with donepezil, and both changes in cognition and change in cerebral blood flow were tracked, you can see that at 1 month there was an improvement in cognition in blue, the group that were responders. So the responders that actually improved in cognition also improved in cerebral blood flow. So there was here a parallel, and this was just the opposite for, in black here, people that did not respond to the treatment. A different study and looked just at the same correlation with a different technology. This was a SPECT. And here they separated in this upper row patients who had at least an increase of 1 point in their mini-mental status exam compared to the other patients that didn't have that improvement. And here you see the different circle areas. I'll just point out to the frontal pole, the lateral, and the medial frontal pole. So the red signals an improvement in cerebral blood flow before and after a course of treatment. And you can see here that people that had at least some noticeable clinical improvement also had noticeable changes here in red of cerebral blood flow, much less so for patients who did not have a clinical improvement as noted here. So I hope I intrigued you by showing this data that this could be really a path to treatment. However, coming back to the light, why the light? It seems really a foreign concept. What can this light do to the brain overall? I will ask you again to go back in time. This time, I'm going to ask you to go back 1 million years ago and think about as you come closer to time zero, which is our time, look at what happened to the brain volume of our predecessor. It steadily increased over time, up to 2 million years ago. Something extraordinary happened here, and for obvious reason, it's very hard to know what happened. But look what happened to our brain volume. The growth was exponential. One hypothesis is that back in the days, I should say back in the million years, our predecessor lost their hair. And all of a sudden, they were exposed to natural light, to sunlight. And that might have really energized our body and our brain. So if that's true, if that happened and the light helped to grow the brain, could the light help now regrow the brain? So this is the light spectrum. We're all familiar with bright light and the use of the SAD lamp. We're familiar with high energy light and the risk of ultraviolet light. The light we're using here is infrared light. It's a low energy light, and so it's a very safe light. So this light penetrates through the skin, the bone, meninges, and gets to the brain. Here, just want to show you some information about the absorption of the light. You can see that the wavelength that corresponds to the different color spectrum, melanin and hemoglobin are absorbing quite a bit of this light. But overall, as you go to the infrared wavelength, that absorption steadily decreases. And as a matter of fact, there is what we call an optical window where this absorption is by the different pigment is much lower. And there is therefore an opportunity for penetration deep into the brain. It's estimated that about 1 to 2% of the light that we shed to the surface, to the skin, actually penetrates to the brain. But what happens when it penetrates to the cell? So this is the cell wall. You can imagine this to be a neuron. And some of the light hits the calcium channel, and calcium become the transduction signal up to transcription. Some of the light reaches the mitochondria. There, it leads to greater production of ATP, a high energy molecule that therefore energizes the cell, and also leads to release of nitric oxide. Nitric oxide is a very prominent vasodilator. So that's an interesting correlation here that might explain some of the benefits of the light. Also, there is a transient spike in free radical and also activation of the nuclear factor K beta. All of these act as second messengers that then induce activation of transcription and eventually, many cascades that I will describe. I will just say that they include the antioxidant inflammatory effect as well. Here is a zoom in into the mitochondrial membrane. The respiratory chain is the target at that level. And that's how the energy from the light, very much similarly to a photosynthetic reaction, leads to production of energy. Now, what are the effects overall that have been demonstrated in animal models of photobiomodulation? I'll start saying that indeed photobiomodulation increases blood flow, which is not surprising based on what I just showed you in terms of nitric oxide release, but also it increases angiogenesis. And it has multiple other effects. There are neurotrophic effects related to the release of neurotrophins that lead to precursors. There is also more synaptogenesis. There are also protective effects with less toxicity, less apoptosis or cellular death, less oxidation as well, an anti-inflammatory effect. So we were very excited about the light, and we wanted to look at whether the light, indeed, even in humans, transcranial light, the one that we can deliver, is 1 or 2%, right? It's a minimal fraction in humans. Whether that could affect cerebral blood flow. So we tested that. This was a collaboration with New York University, with Dan Iosifescu, the PI over there. And we looked through the MRI related bulb signal. So people who received the treatment in the scanner, the effect of the light. Here was our sham, so there was no change in signal before and after. Then we looked at high dose, which was our favorite, where we put most of our hopes, had no effect whatsoever. The low dose actually seemed to worsen the signal. However, the medium dose actually improved cerebral blood flow. So that was very encouraging. And we were fortunate to be funded by the National Institute of Aging and by the Alzheimer Association to conduct a study where we could test that same dose. And here you see the helmet we're using. The study is transcranial photobiomoduulation for Alzheimer's disease, or TRAP-AD. And the same dose in patients with Alzheimer. This is a large multi-center study, includes New York University, Nathan Klein Institute in New York, City University of New York, and Mass General Hospital, and also some players also from McLean. We aim at enrolling 125 participants. We are very invested in, first of all, demonstrating within 8 weeks of double-blind treatment, sham control, whether we can produce significant benefits in amnestic MCI. However, we are also now looking at mild dementia, so both are allowed into the study. Here you see always different angles of the device we're using. We're very interested in safety and tolerability. I will say about that our current participants are tolerating the treatment very well. They just have a little bit of sometimes a little skin warming or a little redness that are fleeting, just few minutes, 10 minutes maybe after treatment, and then all of that is dissipated. The attrition rate is very low, so people stay in the study. What we look at, and we're, for obvious reason, very interested in the correlation with the cerebral blood flow, but also we characterize our patients based on their baseline tau burden with PET, and we also look at the energy metabolism before and after through phosphorus MRS. This is one of our participants that gracefully gave us her pictures during the treatment and consented to us showing her pictures. So the device is comfortable, and so is the participant. Just a quick flow of our study. We do neuropsychological testing at the beginning, a rigorous assessment. We do again at the fMRI, MRS, and PET baseline. Then there is a randomization. Treatments occur for 8 weeks. I said that, but I didn't say that there are 3 times per week. And then we reassess, we repeat the MRS. And then NIA was particularly interested in whether this treatment this potential treatment effect is sustained or not. So we're actually reassessing the benefits at 3 months. Interestingly, participants that do not receive the treatment, and I would say we infer that just based on the lack of improvement during the study, they are then eligible to receive the treatment for sure in open label after the end of their study participation. And many elected to do so. So the study is still ongoing. I don't have results yet to show, but I can tell you a little more about the literature on the use of photobiomodulation, so that you can have an idea of the level of evidence so far. So broadly, the use of photobiomodulation for cognition has been looked at in different studies for healthy subjects, myocognitive impairment, Alzheimer's disease, dementia, but also cognition in mood or traumatic brain injury, stroke, and other conditions. So I will say that there is a sizable number of publications already, and most of them are on learning and memory. Other dimensions of cognitions have been less studied. I will ask you to focus on this yellow-orange, I guess, color here. That's the mild cognitive impairment, Alzheimer's, dementia. And I just want to show you that most of the studies that have been looked at that, specifically that condition and the possible effect of photobiomodulation for that purpose, have just looked at global neurological or cognitive function. So there's still a poor understanding of the dimensional effect of this treatment as a result. The other aspect that I think it's important to really grasp here is that we are at a very preliminary stage. This is obviously not an FDA-approved study. You would have known otherwise, and also there are potential risk of bias in the literature that I'm going to show you. Whenever it's green, that means that there is a low risk, but whether it's red or yellow means that there is a high or there is an unclear risk. And so there are some issues that have been pointed out in this literature, statistical analysis issues, but also some issues potentially with blinding and allocation of to the different treatment arms. Blinding is sometimes can be challenging. The good news is that light is invisible; it's below the visible, so that's good. But there is warming, and so most studies like ours either produce some cooling to mask that, or try to anesthetize, slightly anesthetize the skin, or make a sham condition that has warming incorporated. So a few studies here that I'd like to present to you. So here, this was a study where they shed light not only transcranially, but also on the abdomen. They had about 53 subjects, and they had daily sessions for 8 weeks, and they had a sham control. The patients had mild to moderate Alzheimer's disease. So the overall ADAS-Cog was lower in terms of mean change from baseline. So there was a tendency to an improvement in the treated group here in orange, but that didn't reach significance in this relatively small samples. The comprehension subscore, however, was significantly better in the treated group. And also some tasks like the trail-making task, part B, reached significance in terms of time for completion here in the treatment group in terms of benefits. And so was the 4-wall verbal span. This was the significance, however, was found at follow-up, so 60 days were the treatment span. Now, what you see here is that, unfortunately, some of the effects are lost as treatment is discontinued here after 4 weeks from discontinuation. So some encouraging results from this study. Another study also looked at myocardial impairment, or I would say at least myocardial impairment, a comparable sample of participants treated 5 times per week, but this time just for 1 week. Also sham included in this study. You see here the mini-mental status exam score at baseline. This is the treatment or real group, and this is in gray, the sham group. And then after just that intervention, there was a sizable, detectable increase, a significant increase in the mini-mental status exam. Now, I would again caution on the kind of the magnitude of this finding. I already told you about potential risk for biases in the literature. However, there is a certain directionality that we are seeing here in the literature. Of course, as always, there is a risk of bias in terms of publication as well. Typically, positive findings are more likely to be published. And this is a third study. This was broadly in dementia. The user device that was more inclusive, like a helmet. Other studies were more focal in terms of location of treatment. A slightly larger sample, this time was twice daily treatment, still 8 weeks, and also, again, a sham or placebo were included. Mild to moderate dementia was the inclusion. Now you see before and after, again, the mini-mental, sorry for that, the mini-mental status exam showed a significant change and improvement in the treated group compared to the sham group that didn't quite reach significance. They also showed some results from their clock drawing test, and this is the treated group that seemed to have quite a remarkable improvement. And these are some examples of the placebo group. Now, as we're coming to the end, I will say that my father is doing this treatment according to our family, according to his healthcare providers. There's been some improvement overall. I hope that that will stay. And I also want to put a plug for the MGH Brain Photobiomodulation Clinic. We not only have a study and we're actively recruiting. The study also compensate up to $1,500 for the effort that the patients put in the study. But we have a clinic, so that for cognitive disorders and mood disorder, that clinic is approved by Mass General. The treatment is off-label. We are very cautious about treating only after really explaining that they are FDA-approved treatments, and those are, the mainstay for treatment. But this is another layer that people can opt to try. So with that, I wanted to give a shout out to our team members. There are many, really, this wouldn't be possible otherwise. Also, if you're interested in the topic, interested in the clinic, reach out. You can reach out directly to me here. If you look at this website, is the MGH website for the clinic as well. And with that, I thank you for listening and for inviting me today.
Thank you so much. What a compelling talk, and understanding the mechanism that you're proposing is really important, really resonated. Can you tell us a little bit about the study that you're currently running at MGH and the clinical treatment? If we were to send people over, what would the study involvement look like versus what would clinical treatment look like?
Yes, so they are absolutely very similar. In fact, it's the same device. And this is a high-power device. However, although we consider it high power, the overall light, it's also low-level light. So high power within the power that is usually considered for this type of treatment. So the main difference is that the clinic allows more customization, so more personalization. So if there is a need to increase the exposure time or increase the frequency of treatment, we can do that in the clinic. However, in the study, it's just 3 times a week. It's a set time. And so it's a very rigid protocol.
Can you tell us the inclusion criteria for this study, please?
Yes, of course. The participants need to have a CDR between 0.5 to 1 and a FAST that is not greater than 4. So those are the main entry. We obviously exclude for other conditions that we deem that are very likely to have determined mild cognitive impairment or mild dementia. So if there are clear vascular causes, so like prior history of stroke or sizable lesions in the brain, or protracted history of heavy alcohol use, or history of multiple traumatic brain injuries, concussions. So all of this would become exclusionary. But otherwise, I think we're pretty broad, and we require certain stability in the treatments that are specific to Alzheimer for obvious reason. But we could rescreen or reassess someone after 6 months, for instance. So that wouldn't be limiting.
It's really helpful. If you wouldn't mind sharing the criteria in writing with me, then I will bring them to our memory clinic and start to keep your study and the clinical service in mind.
Yes, absolutely. We would certainly do that.
Okay, thank you. Other questions and thoughts?
I have a question, actually I have a couple of questions, very interesting topic. I just wanted to mention, you noticed in some of the studies that the effect goes down, any improvement over time without treatment. Margaret Naser has done some studies you may be familiar with head injury football players and showed some of that effect too with very small n's, as I recall. I'm just curious if sunlight is sort of the driving force. Is there any study that looked at geographic differences then in things like Alzheimer's? You know, like Northern Europeans versus Southern Europeans, or sort of matched a little bit on standard of living and education and things like that?
So I don't know. And at the same time, I will say that overall, we spend most of our time indoor. So there is an issue there in terms of getting sufficient exposure to infrared light in the current kind of living style or conditions. So I don't know. I'm curious as well.
I had one other question. Thank you for that. What are the major risk factors for treatment, if any?
Yes, so the main factor that you need to consider is that there are two different types of light. One is the LED light, and the other one is the laser light. So if you use a laser light, you have to use protections for your eyes. There is a risk otherwise that if you were to stare into the light, that would converge on the macula and produce lesions. Of course, you know, first of all, we don't shed the light over the eyes. Second, everyone uses goggles that are filtering out the light. So with those precautions, it is absolutely safe to use the light.
Thank you.
Thanks for a great talk. It's a really interesting modality, and I'm sure has a lot of interest amongst our patients and families, because it feels like a fairly benign intervention and one that could have a lot of benefit. So I was curious about whether, I know this is sort of new technology, so I'm guessing there's not research studies comparing, but I was thinking about both the difference between this and TMS, and also the difference between this and SAD lamp therapy that our patients find so much benefit from for seasonal affective disorder, and how light can clearly help people's moods. Obviously, we're talking about cognition more than mood, but I was just curious on your thoughts on those other two currently existing modalities in comparison to this one.
Yes, so I would say one of the main elements that sets apart photobiomodulation compared to any other transcranial neuromodulation, whether it's transcranial magnetic stimulation or whether it's transcranial direct current stimulation or transcranial alternating current stimulation, there are many, is that we are delivering energy to the brain. We're not just driving brain function, we're also refueling as we drive brain function. So that pro-metabolic effect is very novel in comparison to all others. Now, compared to the SAD lamp, there are some similarities in terms of SAD lamp can affect serotonin levels, and so does, at least in animal models, photobiomodulation. So that's there are certainly similarities, but again, PBM, or that's the short for photobiomodulation, can directly neuromodulate brain function is instantaneously. So we see instantaneously changes in cerebral blood flow, but also changes in oxygenation, changes in gamma oscillations or beta oscillation. So that's a direct modality for immediate modulation, and that also, similarly to other techniques, by modulating the parameters, which are many, of transcranial infrared light, you can also modulate the response.
Are you all experimenting on using this as a preventative technique? It starts to kind of conjure ideas of like exercise and increased perfusion and all of the evidence base we have that exercise is really advantageous to delaying onset of dementia. So what are your thoughts about using this in like a middle-aged cohort? Are you using it now?
So we are not. We don't have a study on prevention. I think it's a great study to have, and I'm definitely interested. I'll probably knock at your door.
I would do it. Personally, I would sign up for that. That sounds like a great idea. And even like for cognitive enhancement in people who, let's say, have, kind of subjective cognitive complaints or feeling less than depressed, with like age-related cognitive changes or, ADHD. I mean, I think if in fact it's promoting perfusion, it has some pretty broad implications, right?
I will say that specifically one group from the University of Texas, Austin, has conducted several, maybe say many studies on healthy subjects and cognition, and there are detectable changes in several dimensions, including memory, attention in healthy subjects.
Yeah. Paolo, really interesting area. So thank you for the talk. I kind of wondered a little bit, and I think you touched on this, in your talk, but so the effects, kind of neurochemical effects, and many of these patients are on cholinesterase inhibitors or memantine. So those are commonly used after diagnosis. And I sort of wondered about the difference between kind of the direct effect of light on brain tissue versus could there be any modulating effect on those medications and their mechanisms of action? So potentially could light be making those medications more effective? Did you see what I mean?
Yes.
Whether you separate out patients on medicines versus patients who are medication free.
Absolutely. So I'm not aware of any study that has investigated this specific question. However, we carefully record all medications. So we do have participants that are on one or more, and some that are not taking any. So we could see, of course, adjusting for their level of impairment, because that could be a factor that correlates with the use of medication as well, whether there is any difference in augmenting as opposed to just treating. I think that's something we'll certainly do. Thank you for pointing that out.
Yeah, no, really interesting area.
I may have missed, how long is the duration of the treatment? And are you varying durations to determine study outcomes?
Yes. So I guess I just wanted to clarify that I might have oversimplified the complexity of this treatment. And the reality is that there are multiple parameters that define photobiomodulation. This is also true, by the way, for other neuromodulation techniques. Like just saying TMS, it doesn't really say what treatment someone is getting. And so there's wide variability in terms of duration of treatment. In our study, the duration is about 10 minutes per session. So it's very quick. So what we tell our participants is that although they come in 3 times per week, within 30 minutes, they can come in and out to get their treatment and go, to continue their day. In terms of the overall, I think you were pointing out to this as well, the overall course of treatment is 8 weeks. And we assess right after the conclusion of that course of treatment. And we reassess cognitive function 3 months later to see if there is a sustained benefit.
Yeah.
I'm sorry, was that the 10 minutes a week or 10 minutes several days a week?
So 10 minutes per session, and then 3 sessions per week.
3 sessions a week. Thank you.
Are you planning on other studies with different duration times for each session? I know it's, like you said, there's some variability there, but just curious to see if additional or longer exposure is more beneficial or.
Yes. So I will say that we just recently made a change in the dose. It is a change and it isn't, and I'll just say why. So we use a dose that was a pulse dose, and we changed it to now a continuous wave dose, which means that now the average irradiance is the same. However, the light is continuous now instead of going on and off. So in that scope, we also extended the exposure.
Hi, Dr. Cassano. I was wondering if you could share a little bit of a few of the details of your phosphorus spectroscopy.
Yes, absolutely. So we don't have any results, but McLean Hospital has championed this field of phosphorus spectroscopy, and we're also very interested. We've been in touch with Dr. Feydu and others at McLean. So we are doing, the best of my understanding, and I'm not particularly following or leading myself at that component of the study. We're looking at more static measure of phosphorus spectroscopy, and what we are looking is broadly the pool of phosphorus as indicating NTP levels, so all the nucleotide triphosphate, and we're hoping to see an increase in NTP levels during treatment or after 8 weeks of treatment.
Great, thank you very much. You don't know how you're normalizing your signal, do you?
I don't. However, if you have any specific question on that, I'm happy to get back to you on that.
Yeah, no, that's fine. Thank you.
I think we all want to geek out with you on our own respective areas of interest. It's really, really interesting. Thank you so much for joining us, and we will definitely send some patients your way.
Thank you. Thank you for having me.